Greetings, I'm Salvador Mojica. I'm a retina and cataract surgeon at the National Medical Center at Puebla, Mexico, and at my private practice. In this video, I will be exposing a surgical case regarding a 64-year-old male patient that just had cataract surgery 30 minutes prior our arrival, where a posterior capsule break occurred and some cataract fragments remain at vitreous cavity. The surgeon was able to introduce the intraocular lens and place it at the sulcus, which was a great advantage for the recovery and final improvement on his final visual acuity. Regarding the patient, he had a long evolution type 2 diabetes and hypertension. He was also diagnosed with proliferative diabetic retinopathy, which was modified by argon laser therapy. First of all, I want to apologize for the quality of the video. Since it was not a planned surgery, we didn't have a recording device at hand, so everything you're about to see was recorded by a phone. So the first thing we did was to do an anterior vitrectomy, so we don't have any vitreous remainings near the lens, so we don't have the possibility of the lens moving out of place. After doing a successful anterior vitrectomy, we now continue to do a posterior vitrectomy via pars plana. So the device that we almost always use to achieving a good retina surgery is the Oculus Biome. One of the things that I always have in mind and I tell my residents is that any kind of surgery needs to have patience. It doesn't matter if you're a fast surgeon, you need to have patience. A lot of complications, a lot of risks can be avoided if you have a right pace and patience. It's way better to take double the time on a surgery than do it on half the time and have risks or complications that could potentially destroy all of your good work, even if you have a great technique. Another thing I believe is extremely important is for you to be comfortable. You need to have the right height, the right focus, the right zoom, and the right chair. Otherwise, you're only thinking of finishing the surgery quick because your back hurts. It's extremely important. Usually, a retina surgery can take from 1 hour to 2 hours or more, so you need to be comfortable. Even though the purpose of this surgery is to take away the remaining cataract fragments out of the vitreous cavity, that doesn't mean it needs to be the first thing we need to do. The first thing we need to do is to really verify that we have a posterior vitreous detachment, and if we don't have it, we have to do it ourselves. After we know we have a successful posterior vitreal detachment, now we can start our central vitrectomy and our peripheral vitrectomy. This may be the less exciting step on the retina surgery, but it is extremely important so we can avoid consequences on the health of our patients in the future. In this patient, we can see a lot of the damage that his diabetic retinopathy has achieved in his eye. We can see a lot of the marks of the argon laser, as well as some proliferative tissue from the optic nerve. One of the most important things to remember in this surgery is that we need to protect and respect the macular area, because if we do a bad movement or if we start to move fragments of the cataract near it, we can provoke edema, bleeding, or even breaks. After we achieve a successful central vitrectomy and peripheral vitrectomy, we can move on to the purpose of this surgery. The best way to protect the macular area is with the use of perfluorocarbon liquids or heavy liquids. So we can truly be modifying and moving all of the cataract fragments without the risk of involving the macula. When applying the heavy liquids, we need to apply it with the Charles cannula in one bubble, since it can produce the fish eggs visualization that takes away a lot of our practicity. Now that we already have our heavy liquids protecting our macula, we can be careful, but we can now move all of our cataract fragments and start eating them according to our parameters. After we finish taking away all of our cataract fragments, we are able to take away all of the heavy liquids with the same Charles cannula that we used to inject it. Finally, and specifically in this patient, we took away all of the traction that was involving the fibrovascular tissue near the optic nerve. After that, we finish our surgery. We can take away all of our trocars, we can close the eye without the need of any sutures, and we start applying the topical antibiotic to prevent endophthalmitis. I hope this video helped in your education and helping you to perform great retina surgery. Thank you for your time.